If you've been told you have degenerative disc disease and you've spent the last year or two moving through a sequence of procedures that had each addressed one small piece of your spine, an epidural here, a nerve block there, radiofrequency ablation on one side, then the other, now maybe a surgical consult, and you still do not feel like anything has actually been solved, I want to offer you a different way of looking at what's happening. Not a different treatment yet, a different understanding. I'm Dr. Tammy Penhollow. I'm a physician specializing in spine and joint care. Your spine is an organ, not a stack of bones, not a series of discs, not a set of nerves that can each be addressed independently. An organ, a functional unit, a system in which every structure depends on every other structure to do its job. We call this the functional spinal unit. And once you understand how it works as a unit, the way degenerative disc disease is typically managed in traditional pain care starts to look really different. When a disc loses hydration and height, which is what degeneration means at its most basic, it changes the load distribution across the entire spinal unit. The disc was doing a job. It was absorbing force, like a shock absorber. It was distributing load and creating space. When it cannot do that job as well, that force has to go somewhere. It goes posteriorly to the facet joints, the small little joints in the back at each vertebral level. They're not designed to carry that load on their own. And over time, they begin to degenerate under it. As the facets degrade, the load shifts again, this time to the ligaments at the back of the spine, the posterior ligamentous complex. Ligaments are not designed to be primary load bearers either. They stretch, they become lax, like a rubber band that's been stretched far too many times and then it's just floppy thing. Ligamentous laxity changes the sensory input the spine sends to the brain. The proprioceptive signal, the signal that tells your nervous system where you are in space and time and how to stabilize, becomes unreliable. The multifidus muscles, which are the deepest stabilizing muscles of the spine and the ones that are responsible for segmental control, begin to shut down. Not because of weakness in the traditional sense, but because pain and altered proprioception inhibit them. The nervous system pulls back on the activation signal. And when the multifidus muscles cannot do their job, the disc takes on more load again. This cascade feeds itself. Disc degeneration leads to facet degeneration, leads to ligamentous laxity, leads to multifidus inhibition, leads to accelerated disc degeneration. This is not one problem. This is a system that is progressively failing at every level simultaneously. And that's why treating one level, one structure, one nerve at a time does not stop the cascade. You present with back pain, possibly leg pain, sciatica. Imaging shows disc degeneration. Maybe a bulge, maybe some facet arthropathy, maybe some foraminal narrowing. Traditional pain management approves an epidural steroid injection through the insurance. One level, maybe two. You do it. You might feel some relief. It fades. You go back. You're approved for a medial branch block. This is a diagnosis injection to the nerves that supply the facet joints. You do one side. You do it twice, confirm the result. Then you go back for the radiofrequency ablation, a procedure that uses heat to kill the nerves on one side. Then you go back for the other side. The facet pain might be quieter now, but the disc pain remains. So now the conversation shifts to the disc. Maybe a discectomy is discussed, maybe an intradiscal procedure, maybe a referral to a surgeon for a discectomy, or maybe even a fusion. Or there's bony pain, vertebrogenic pain coming from the vertebral end plates. And now there's a conversation about burning the basivertebral nerve, a newer procedure designed to address that specific pain generator. Each one of these steps addresses one structure, one nerve, one level, one pain generator. None of them address the organ. None of them interrupt the cascade. And the patient who has been through 3 years of this sequence is often no closer to stability than when they started, because the system that is driving the degeneration has never been treated as a system. This is where I want to be specific about what a comprehensive approach looks like. Tower of Power spine. The first priority is stabilization. If the multifidus is inhibited, if the deep stabilizing system of the spine has shut down, no injection, regenerative or otherwise, is going to hold the way it should. You can't put biology into this unstable environment and expect it to thrive. The mechanical environment has to be addressed first. This means deliberate, targeted core stabilization work. Not general exercise, not planks for the sake of planks. Neuromuscular re-education of the deep signal stabilizers so that that segment is supported before we ask it to respond to treatment. If somebody's had already radiofrequency ablation, meaning the nerves to those stabilizing muscles were intentionally deadened, we have a more complex situation. The muscles supplied by those nerves have atrophied. The instability that creates is real. We have to rebuild what was lost before we can build forward. The second priority in Tower of Power Spine is the metabolic and inflammatory environment. The spine is not separated from the body it lives in. A patient with elevated systemic inflammation, with insulin resistance, with nutritional deficiencies that impair tissue repair, that patient's disc and facet and epidural space and ligamentous tissue is healing in a compromised environment. We address the labs. We correct the deficiencies. We optimize the biology before we ask it to do something hard. Anti-inflammatory nutrition is not optional here. It's part of the treatment. The third priority is regenerative care, and this is where the spine requires specificity. Not every structure in the functional spinal unit responds to the same tool. The disc is the most demanding. It is avascular, meaning it has almost no blood supply of its own. It's a difficult environment to reach and a difficult environment to treat. For intradiscal work, bone marrow aspirate concentrate is the most durable option we have. The cellular content, the growth factors, the environment it creates is simply the strongest biological tool for a structure that is largely cut off from the body's normal repair mechanisms. PRP may have a role in younger patients, may have a role in earlier stage disc involvement, and in the surrounding structures. But when I have bone marrow available, I use bone marrow for the disc. The biology is more complete. The durability is better. The case for it is clear. The facet joints, the epidural space, the ligaments, the muscles, each of those structures gets addressed according to what the structure needs. This is not a one-size-fits-all injection. It's a thoughtful, sequenced, comprehensive treatment of the organ as a whole. I want to say something directly here because it matters for the decisions you are making. The spine is the most complex structure in the musculoskeletal system. Intradiscal treatment is advanced. It carries higher technical demands than intra-articular injection. The disc is not a forgiving environment. Precision matters. Experience matters. The understanding of what you're treating and why matters. When a disc needs treatment and it's not treated, the patient is underserved, regardless of how well everything else was addressed. If the disc is the primary pain generator and it goes unaddressed, this cascade continues. The differentiator between a good outcome and an outstanding one is whether the whole organ was treated, not just the pieces that were accessible or approved. Before you agree to the next procedure in the sequence that's been treating your pain, your spine one piece at a time, ask a different question. Has anyone treated the whole organ? Is anyone looking at the disc and the facets and the ligaments and the stabilizing muscles and the metabolic environment together as a unit and building a plan that addresses the cascade rather than one pain generator at a time? If the answer is no, if what you've been offered is another isolated injection, another nerve block, another referral to a surgeon for a single level procedure, you've not yet had the conversation you need to have. The spine responds to comprehensive care in ways it simply cannot respond to fragmented care. If you pursue comprehensive treatment of the spine as a functional unit, you interrupt this cascade rather than managing its symptoms one level at a time. You address the disc, the most demanding structure with the most durable biology available. You give yourself the best likelihood of staying out of the operating room, regardless of what the surgeon has been recommending. For a spine that might have responded differently if the organ had been treated as an organ from the beginning. These conversations are meant to help you think more clearly about your options. For some people, understanding this is enough to start making better decisions. For others, they want structure, sequencing, and accountability. These options are in the description if and when you're ready. I've also put together a free resource called The Patient Guide to Ethical Regenerative Medicine if you want a clearer framework before making any decisions. And if not, keep learning. That's always a good next step.